Welcome to Curing with Sound, a podcast presented by the Focused Ultrasound Foundation. In this episode, we explore the science of pain, what it really means to live a pain-free life, and how focused ultrasound is reshaping the future of treatment. This special episode is a condensed version of a webinar presented by the Foundation in early 2026 and hosted by Dr. Suzanne LeBlanc, the Foundation's Director of Clinical Relationships. We'll hear first from CNN's Dr. Sanjay Gupta, who offers a fresh perspective on pain from his book, It Doesn't Have to Hurt, Your Smart Guide to a Pain-Free Life. He reminds us that pain isn't just a physical signal, it's an experience shaped by the brain, influenced by how we move, sleep, and manage stress. Then, Dr. Lauren Hadley, the Foundation's Associate Director of the Research and Education team, walks us through how non-invasive focused ultrasound technology is being used to target pain at its source, without surgery or long-term medications. And finally, we hear from Reginald Masters, a patient who found relief with focused ultrasound after years of back pain.
I know that you're a neurosurgeon and you've seen the inside of the brain and you've been in exciting operating rooms. So why did you decide to write this book about pain?
You know, I've been thinking about pain for some time, and I will just preface by saying it took me, over 3 years to write this book. Yeah. I think for a lot of docs, myself included, we're treating patients who have pain, and I knew for a certain percentage of them, not an insignificant percentage, surgery was never going to be the right answer for them. For some reason, their pain persisted and lasted beyond the sort of time period that you think an injury to the tissue or trauma would last. And I just found that whole thing to be quite mysterious. I remember I talked to my publishers about this, and one thing about writing a book, as people may know, is that they will look and see what else has sort of been written about pain that's out there. And interestingly, despite the fact that at least a fifth of our population suffers from chronic pain, there had not been that much written about it. When I published the book, it was the fastest growing condition in the country, faster than diabetes and dementia, which I thought was very interesting. And as you correctly pointed out, Suzanne, those numbers translate globally. So for some reason, as a species, humans are in more pain than we've ever been before. That pain seems to persist longer than it has before. And we haven't had a lot of great options, at least a lot of options that people know about. So I thought, it would be good to sort of explore what is pain. And this is in some ways as much a metaphysical question as it is a medical question, but also to be really, I think, as thorough as I could be in terms of looking at what else exists out there. We've become sort of a binary culture, opioids or no opioids, procedure or no procedure. But there's a huge, huge middle ground that I thought wasn't getting enough attention. And that really kind of inspired the book.
Yeah, very well said. And you talk about it being metaphysical. And in the book, you talk about it being a mysterious human sensation, right? Some people feel pain more than others. Where does it really originate from? Can you talk us more about what you learned about that and how you feel about it?
I remember talking to a couple of neuroscientists who were very focused on pain, and they were making this point to me that I thought was very interesting. I was approaching it from this idea, like, how do we objectify pain? How do we measure it in a way that is shareable, that can provide context for someone else? When you tell me, Suzanne, you're in pain, that I have a basic understanding of what exactly you're experiencing. And what these neuroscientists basically said to me is, stop barking up that tree. This is a truly unique human experience. Not only is it variable between me and Reginald, for example, but it is variable within me, hour to hour, even minute to minute. Like, you could take my thumb and smash it with a hammer on a Tuesday, and I could describe that experience to you. I could do it the following Wednesday, the exact same thing, and have a very different pain experience. And it might be influenced by things that are seemingly arbitrary. Had I eaten that day? What was the weather like outside? Had I had a difficult call with my mom? All these things that you don't necessarily think about in terms of amplifying or mitigating your pain experience And yet it happens, So I tell this one story, I'll share with you just on a personal note. When I was young, around 12 years old, I was having a perfectly lovely day. It was a really nice day outside. I was running through our neighborhood and thought that I could vault myself over this fence that I would normally go around. So, put one hand on top of the fence, vault your legs over the fence. It had these spikes across the top. Well, I didn't make it. And the spike went literally right through the back of the skin on my right side of my torso and came out the front. I was pinned on this fence. It was high enough that I couldn't put my legs up to get. I know this is making people squeamish a little bit, but this was like the first time I really experienced significant pain. But I was pinned. I couldn't move, and so as a result, I was just up there for a while, like several minutes, like I think 10 to 15 minutes, and really absorbed the whole feeling of pain. And what was interesting is that it wasn't anything like I would have expected. First of all, it didn't feel like a sharp poker going through my back. It felt like someone had slapped my back really hard, like with their hand, number one. And that's because the density of pain receptors in your back is much less than, for example, on your finger. I didn't realize that at the time. I was only 12 years old, but that idea that pain can feel very different even within your own body, different locations. And then after a while, Suzanne, the pain really started to come and go. There were periods of time when I would say that I really didn't have any pain, even though I was pinned up on that fence and I had this spike going through my body. I didn't feel. Then the pain would come in a wave, and it would come like that again. And what I realized in retrospect, it was my own opioids that my body was surging into my body that was helping alleviate the pain. Point being that this was a mysterious experience. I didn't fully appreciate it at the time, but as I reflected on it over the years and I talked to my own patients and they described these very painful experiences, but then what they described their experiences is very different than what someone else might or I would. And I think that just made it all the more mysterious. I mean, this is, 3.5 pounds of the most mysterious tissue in the known universe, I think. And I think pain is sort of the ultimate manifestation of that. It is a truly mysterious, unique human sensation.
Well, it's interesting that you say that it waxed and waned, with maybe some endogenous opioids being released. So in your book, you do talk about some strategies that perhaps allow you to control some of that response.
Yeah, absolutely. I think that was one of the great learnings here. First of all, our endogenous opioids, the opioids that we make ourselves versus exogenous or external opioids that you might take in the form of a pill. It's very interesting because so many of our medicines are inspired by our own bodies in some way, and opioids is a good example of that. The problem is that it's very hard to replicate what the body does. So if you sort of break it down into three things, opioids decrease pain. We know that. They affect mood and they affect memory. When it comes to your endogenous opioids, the opioids you make, they're very effective at relieving pain. They're also good at improving mood and decreasing memory of an event, sort of making you more amnestic to the event. I say, were it not for our endogenous opioids, no woman would probably have more than one child because it's a painful experience. But you have this biological imperative to sort of forget something that's that painful, or at least not remember it as well. Exogenous opioids, ones that you take by pill, are also very good at relieving pain. That's they're good at, but they're terrible for mood, and they oftentimes increase the memory of an event. So you're more likely to almost have a post-traumatic stress in relationship to the event if you use opioids to treat the trauma. This has all been pretty well documented. But that was one of the things that really made me think, what else, to your question, can you utilize to sort of harness your own endogenous opioids? I'm a firm believer after 25 years of reporting, simply explaining this to people, that this opioid system exists and that it is within your control to some extent, allows them to believe that and figure out the best ways to control it themselves. But we do know, for example, meditation, and specifically, I'll share a protocol called the MORE protocol, Mindfulness Oriented Recovery Enhancement Protocol. developed by Eric Garland at UCSD, was really effective at alleviating both acute pain and pain that was on the verge of becoming chronic pain, which is pain that lasted at least 3 months every day or 6 months every other day. And it's a mindfulness protocol. There's several steps to it, which you can look up or you can read in the book. But I will say that I was so fascinated by this that I flew to San Diego and just spent a few days in the lab with Dr. Garland. And one of the experiments they did was they used these heating filaments, which is one of the ways they try and measure or give a constant sort of dose of pain to someone. And there's these heating filaments that sit on your arm, and it's hot enough where you'd want to recoil your arm away. And they basically give you 5 pulses, and they're measuring pain and they're measuring unpleasantness. It's a long experiment, but the headline is that I went through that. Then I went through the mindfulness-oriented recovery enhancement protocol, and then did the same experiment again. And that 5th pulse of heat, I didn't even feel. I didn't even feel it. And the unpleasantness scores dropped from an 8 to a 4. Wow. So it wasn't just the pain, it was the suffering that was also mitigated or reduced by the mindfulness. It's really fascinating. I mean, look, I'm careful not to overstate this, but it's not something that's durable. Like during the time that you're meditating, people who have chronic pain can often take their pain scores down to 0. It doesn't mean it's going to last forever. I mean, when you're done meditating, you may get a resurgence of that pain, just like you would with pain medications as well. They have a half-life, they're not going to last forever. But I think this idea that what you're fundamentally doing is just harnessing these opioids, which are circulating in your body already, and basically telling them to get to work. It's not just distraction. People thought meditation was all about distraction from the pain. It's not just that. It is actually this biology that's increasing the amount of opioids that are actually functioning within your body. And that's very inspiring. I think it's very empowering for people.
Well, I learned a lot of that in your book, and also hearing you say that, it really makes sense now. And I'll share with everyone that I went through breast cancer about 10 years ago, and I did use a lot of meditation and mindfulness practices. And it's just like what you said, it didn't last forever, but during the time I was doing it and shortly after, I did receive a lot of benefit from it. It helped me get through my treatment, and I repeated it. So now I understand the science behind it. So thank you for explaining that.
Sure. No, it's wonderful, and I'm glad you're doing well. I know that can be a very painful experience, but I think there's a lot of people who are not believers in meditation, who with this MORE protocol, they trained 1,000 practitioners around the country, and they started embedding them in these pain clinics all over the country and in Canada. And the results were pretty remarkable. As a clinician that oftentimes people will say, well, how effective? Like, give me context for this. We want data, we want evidence. Some of these things are hard to measure, but what Eric Garland and his team basically concluded was that a MORE session, mindfulness-oriented recovery enhancement session, was about equivalent to 5 milligrams of OxyContin, which is something that people may better understand. That's an opioid. That's one of these opioids we keep talking about. You can achieve that same level of pain relief, and maybe even that same length of pain relief, without taking medications at all.
Thank you for that interesting discussion. So I wish we had more time, but for now, we're going to segue into Dr. Hadley. She's the Associate Director of the Foundation's Research and Education Team, and she's going to talk about how focused ultrasound can play a role in pain management and the immense potential that it can add in treating really painful conditions as well. So Lauren, let's hear from you.
Thank you. I'm going to show a presentation here, and then we'll have some discussion afterward. But I think a lot of what we've talked about today, there are definitely some parallels with different interventions and also listening to patients. And so I'm really, really thrilled to have a discussion after you hear about the great things that are happening with focused ultrasound.
Okay, great.
Thank you, everybody, for joining us today. With the next 15 minutes, I'm going to review how focused ultrasound is being used to treat some of the most painful conditions, which we hope will eventually lead to less medication consumption and a safer, repeatable, non-invasive treatment modality for some of these disabling pain conditions. So before I get started into some of the very exciting things that are happening within focused ultrasound, I wanted to review with you the mechanisms of action that are involved in treating painful conditions. Focused ultrasound can relieve pain through several distinct mechanisms. The first two mechanisms rely on what we call thermal ablation. This is where high-intensity ultrasound creates small targeted thermal lesions. When these lesions are made at the source of the pain, the focused ultrasound ablates around the painful lesions, such as bone tumors or arthritic joints. And when we do this, it interrupts the pain signal at the site before it's able to transmit that signal back to the brain. This approach is being studied to treat and is commercially available to treat painful bone metastases, so cancer that spreads to the bone, osteoid osteoma, which is a very painful benign bone condition, pancreatic cancer pain, back pain, and knee pain. Thermal ablation can also be performed inside the brain, so that's second category of thermal ablation, along circuits in the brain that are involved in pain processing. With MRI-guided targeting, precise lesions deep in the brain are being investigated to treat neuropathic pain, trigeminal neuralgia, and head and neck cancer pain. At lower intensities, so not high intensity focused ultrasound, but low intensity, the focused ultrasound doesn't create lesions, but it modulates neural activity, and we call this neuromodulation. And neuromodulation influences the signaling in both the brain and in the spine in different treatment indications. And it offers a reversible way to dampen dysregulated pain pathways. It's being studied clinically for chronic pain, including fibromyalgia, and degenerative disc disease and post-stroke pain. And then a fourth emerging mechanism, which we're excited about, is targeted drug delivery. And in this case, ultrasound-responsive nanoparticles that carry pain medications release the drug only where ultrasound is applied. Now, this enables highly targeted drug delivery to specific brain regions, potentially increasing the effectiveness of medications and also potentially reducing systemic exposure of that drug and thus reducing the risk of harmful side effects. Together, these mechanisms illustrate how focused ultrasound can be tailored in different ways using either high or low intensity to treat different types of pain, from cancer pain, arthritis, and fibromyalgia. Now, as you can imagine, given the breadth of focused ultrasound mechanisms I just described, there are several different technologies or devices that are being used to treat these various types of pain through the various mechanisms that I mentioned. This can be broken up into body systems and brain systems. The body system treat areas of the brain and really target the sources of the pain, and the brain systems, again, target those dysregulated neural circuits. The body systems are profound Sonolieve, and the Sonolieve system is an MRI-guided system that is being studied and is commercially available as well to treat painful bone metastases, osteoid osteoma, and back pain. The second body system is the FUS mobile neuralizer device. This device is guided by X-ray, and it is used to treat back pain, and I will highlight this specific company and device a little bit later. The brain systems include Insightec X-Ablate Neuro, which is an MRI-guided system that mostly employs thermal ablation to treat various types of chronic pain, and then two investigational neuromodulation devices, the Spire Diadem device and the Brain Sonics device. And these two devices, again, employ neuromodulation, so low intensity of ultrasound, to treat different types of chronic pain, including fibromyalgia. Now, there are a lot of other investigational neuromodulation devices that are coming into the scene, and those are still in early stage development. So I'm going to forgo talking about those, but I will just acknowledge that there are a lot of emerging neuromodulation companies coming online, and we're excited to learn about how they use those to treat chronic pain. This slide indicates the regulatory stage for focused ultrasound. So really the state of the field when we think about regulatory approvals and commercial treatment availability. So the first two pain conditions listed, painful bone metastases and back pain caused by facetogenic arthritis, or arthritis of the facet joints in the back, have received US FDA approval as well as international approval. Central neuropathic pain, which is a condition where there's abnormal firing of specific circuits in the brain that leads to pain, is also approved internationally, but not yet in the United States. All of the remaining painful conditions or indications that are listed in this slide are still being studied in clinical trials. And that includes degenerative disc disease, which is another source of back pain, sacroiliitis, yet another source of back pain, low back pain, knee arthritis, which, as you know, is very common, trigeminal neuralgia, head and neck cancer pain, pancreatic cancer pain, fibromyalgia, central post-stroke pain, and chronic pain. So all of those conditions are being investigated with focused ultrasound to see if we can create effective non-invasive therapies in those specific conditions. Now, with this in mind, I'd like to turn your attention to highlight a few recent scientific and regulatory advancements in the field. So the first is a recent regulatory success. In November of 2025, the FUS Mobile Neuralizer XR device, which I mentioned in the beginning as one of the body systems, was granted de novo marketing authorization, meaning that it is now commercially available to treat U.S. patients that have the condition called facet joint arthritis or facet joint syndrome that causes about 1/3 of all chronic back pain cases. This device did already have approval in Europe and Canada as well. So facet joint arthritis is an inflammation of this joint in the back called the facet joint. And one of these nerves, called the medial branch nerve, actually supplies the innervation to that joint and then transmits painful signals back to the brain. With the FUS mobile device, it deploys focused ultrasound to that medial branch nerve and ablates that nerve, thus disrupting the pain signal back to the brain. And over about 500 patients have been treated with this device, and half of those have been commercial treatments. And patients have really communicated back that their pain is successfully controlled. And we actually have a patient joining us today who we'll hear from that can share that experience. The thing that I like about this device is that it is guided by X-ray fluoroscopy. And the reason that that's important is because the standard of care intervention for this type of back pain is something called radiofrequency ablation, or RFA. And RFA is where needles are inserted into the back. And the clinicians who use RFA utilize the same guidance technique of X-ray fluoroscopy. So they're very familiar with the workflow. So adding focused ultrasound to their armamentarium of treatment options will be very easy and is streamlined. And given the non-invasive nature of this technique, patients with needle phobias or that just don't want to undergo an invasive procedure can have the advantage of now a non-invasive treatment option. The company is also investigating other types of back pain. So sacroiliitis, one of the other indications that I mentioned, they are looking into this device for that condition as well, and the foundation is funding that study. The second highlight I'd like to talk about involves clinical trial progress for head and neck cancer pain. So head and neck cancer pain is pain that originates from cancers that arise in the head and neck. One of the most common of those, or an example, is tonsil cancer. And so with this, results that were recently published from a pilot clinical trial showed safety of thermal ablation in a specific part of the brain called the mesencephalon, or the midbrain. And the midbrain, in this particular instance, was shown to have an effect in the pain processing for head and neck cancer pain. And so they thermally ablated an area within the midbrain, and they found that this was safe and that patients received some clinical pain relief benefit. And for that reason, it has now paved the way for this multi-site trial, which will include 20 patients at 6 sites throughout the United States. The goal being that this indication with thermal ablation of the midbrain will lead to regulatory approval. And the history of mesencephalotomy, or ablation or disconnecting the circuitry in the midbrain to treat pain, has been around for a while, although the techniques that were used before this non-invasive approach were extremely invasive, and so never really gained traction for that reason, and also had some other deleterious side effects. So we're hopeful that this multi-site clinical trial will point to a safer and effective treatment option for patients who suffer from head and neck cancer pain. The foundation is also funding this multi-site trial. Lastly, I wanted to highlight a recent development in a condition called central post-stroke pain. And this information came from a publication out of China. And this specific publication is called a case report. And case reports are used in medical literature to describe individual patient reports that are noteworthy and often include novel treatment approaches. So this specific report was on a 66-year-old male who had severe central post-stroke pain, or CPSP. And CPSP is persistent or intermittent pain following a stroke. The pain is often described as some of the most excruciating pain that one can experience, and very disabling. This case was about a 66-year-old male who had CPSP, and his pain was described as a burning sensation along the left side of his body. Now, the left side of his body was paralyzed secondary to the stroke. He also experienced anxiety and depression secondary to his pain. And he described the pain as very painful, burning, even to light touch or putting clothing on his skin. So very disruptive. The treating clinicians who were involved in the care of this patient had heard about focused ultrasound neuromodulation for other types of chronic pain, and so they wanted to experiment with this technique. And he had an abnormal signal on his functional MRI, so they targeted that area with focused ultrasound neuromodulation and for 7 days. And what they found was that the patient experienced very effective pain relief after this neuromodulation session of 7 days of neuromodulation in this area. The area is called the cingulum bundle. So a pretty durable response to this neuromodulation. Even though it was 7 days, the patient experienced relief up to 150 days after the procedure. In addition to the pain relief, he also was able to wean off all of his pain medications, and he had much less anxiety and depression. So this single case report, although it's just a report of one patient, highlights the promise of focused ultrasound neuromodulation to treat chronic pain, specifically central post-stroke pain and other types of chronic pain as well. And there are a number of other neuromodulation trials that are aiming to investigate neuromodulation's effect on chronic pain. So that is all I wanted to share with you today. And I hope that you have seen that focused ultrasound holds immense promise as a non-invasive treatment option for some of the most disabling and common painful conditions. Thank you so much for listening.
Thank you, Lauren. That was a fantastic overview of the mechanisms of action and various indications that we're exploring to use focused ultrasound for pain. And I know you mentioned a few of the manufacturers. I want to reiterate that the Focused Ultrasound Foundation is a nonprofit, and we are agnostic to the manufacturers. We work with over 70 to 80 manufacturers in this space. We have no financial interests in them. We just help the field proceed to be able to help patients in the future. So thank you for giving us a taste of that all. So now I'm very, very excited to have Reginald Masters with us today. He is a patient that has unfortunately lived with chronic pain for decades following a traumatic workplace injury in his 20s. He enjoyed life for many years after with some relief due to some interventions, but the pain returned and worsened in 2016, despite trying a range of holistic approaches, prescription medications, and over-the-counter medications. He was still in pain, so he underwent a focused ultrasound procedure with the neuralizer device that Lauren just explained. And he experienced relief, which you'll hear from today. He was treated under the supervision of Dr. Michael Gofeld and Dr. Kevin Smith at the Unica Medical Center in Canada. And with less pain, life has changed for him. So I hope you'll enjoy hearing from him. So Reginald, welcome to the webinar.
Thank you very much. I appreciate you having me on here.
Oh, absolutely.
I've learned a lot.
Well, maybe you could tell the audience, what was your pain like prior to the focused ultrasound procedure, and what were you doing to try to control it?
We talk about pain on a scale of 1 to 10, and for a lot of the time I was 6, 7, 8, and it would come and go, but it was basically the fear of improper movement that was going to cause it to spaz. And so simple things, pulling on socks, pulling on my boots, standing at the sink to brush my teeth, things like that, leaning forward. Every step sometimes would be a jabbing pain. And in your head, in your brain, it tries to minimize that. And so for a long time, I used some pretty heavy stuff. I was on buprenorphine patch, which is fentanyl's little sister. And the problems with that drug is that it changes who you are. It changes you emotionally and mentally. Some would say it's a personality intensifier. And if you're having a bad day, that drug actually, I think, made it worse. So wanting to get away from that, I tried many holistic things, chiropractic, massage, acupuncture. They all helped, but nothing came close to the ablation. It was.
Yeah. So thank you for sharing that. And I'm sorry that even activities of daily life seemed almost impossible. And like what Dr. Gupta was saying, it changes your personality. Like you were just explaining that. So how did you hear about focused ultrasound? And can you tell us about the procedure and what it was like to undergo this procedure?
I heard about it through my sister, who also has a lower back issue.
Oh.
And she actually had an appointment right after I did. And she also received fantastic pain relief. So the procedure, you're face down on the bed, they put the gel on your back. It's like a silicone dome that focuses he uses I don't know the proper terms, the neuralizer.
Okay.
And it is a minor discomfort, but it's only a few seconds, 45 seconds. And Dr. Gofeld was very patient with me. He's like, okay, count down 15 more seconds, 10 seconds. Okay, you're almost done. You're done. And when I got off the table, after he did, let me think here, he did between 2 and 3, 3 and 4, 4 and 5.
Okay.
And so I was, I think, a little better than a half an hour on the table. Very comfortable, nothing. And when I stood up, his assistant said, okay, how do you feel? And I was like, we do the test, right? We do the mobility test. And it was gone. Instant.
Wow.
So it's pretty hard to beat. Pain-free is what we strive for.
And compared to other procedures where you had needles put inside you, how would you compare it?
3 out of 10, like versus. So I've had sciatic ablation.
Mm-hmm.
That's pretty aggressive. I'm not going to lie, it's painful. But again, from that, I got 8 months of relative pain-free from sciatic pain. But if this ablation, when they first did it, they didn't know how long it was going to last. I'm guessing it's worked better than they thought. It's worked better for me than I expected.
That's
and
great.
my sister as well. So,
And how long has that been?
I think it was November 4th, I think, was my ablation. So December, January, February. Yeah, we're 3 months, heading into 3 months. So it's worked.
And what kinds of things can you do now that you couldn't do before?
I'm not afraid of rolling over in bed. I'm
Right.
not afraid of pulling my socks on. So the other thing too is what we talked about earlier. I'm not afraid to do a little bit of movement. So some exercise now.
Nice.
There's no way previous to this, there's no way I would have been doing the stretching, and I'm doing Tai Chi for old guys, and just that movement has really helped.
Dr. Gupta, do you have any questions for him?
No, well, I mean, that's pretty extraordinary. And I am obviously curious how long this lasts for you. Did they tell you that you're likely to need other treatments, or what is your expectation?
They thought 4 to 6 months is what Dr. Gofield originally had said. And to be honest, Dr. Gupta, if I have to go back in 6 months, I'll do it in a heartbeat.
And you were not anesthetized for this. Were you made sleepy at all? Did they give you anything to make you sleepy or sedated?
No, I chose not to. And I think, so we talked about pain. You talked about pain tolerance and what you perceive as a 6 out of 10 and what another person perceives as a 6 out of 10. I had no sedation, no anesthesia, and I didn't think it was that bad. In fact, I don't think I'll get it next time. It didn't bother me that much.
And are you left with numbness at all, or is there numbness as a result of what they did to the nerve, or are you just pain-free?
No, just pain-free. Just pain-free. So the live pictures that they showed me, he says, no wonder you have back pain. He says you've got you've got no disc left between 2 and 3 and 3 and 4. So he said that's why, he says that's why you have this facet joint pain. He says because the facet, they're basically resting on each other instead of having that space. Mm-hmm. Okay, I understand now. So if the treatment worked for me and it worked for my sister as well, how many more people can benefit from this? And it's a very specific area. What's the next thing? Is it going to be, joint knee pain, joint pain, shoulders, whatever it is? If this can help other people, I'm glad to be a spokesperson for it, poster child, whatever you want to call it, because it made a huge difference.
Amazing.
Huge difference in my life.
And Lauren, this is one of the FDA approved procedures.
Yes.
Is that right?
Yes. Yep. Yeah. So this is recent FDA approval in the United States. So just November. And so, I think moving forward, with this specific ablative technique, this is the first U.S. FDA approval. And I think the charge now is going to be getting this technology to more hospitals, more clinicians, and thus more patients. So
thank you very much, Reginald, for joining us today. And I'm sure everyone on this call admires your determination with all of the things that you've tried and contributed to improving your pain, and then, trying a new, completely innovative incisionless treatment. So I'm so glad that you're better. And Dr. Gupta, again, we're so thankful to have you here. Is there any last words of advice for patients or anything that you wanted to talk about from your book that we haven't been able to discuss yet that you want to impart to everyone?
I think that, the big thing that came out of the book for me was I think there is a sense of hope. I mean, one thing that we have seen in the medical establishment, and this is the way things happen sometimes. I'm not saying this is a good thing, but, I think this was not a book that I wanted to write about the opioid epidemic. A lot has been written about that, but there were these ripple effects of opioid being such a dominant player in pain for as long as they were, close to 30 years. It's reduced a great deal now. People are much more judicious about using opioids, but as we know, it was used really, really liberally for a long time. what happens in medicine is that becomes sort of the gold standard. And, every year the FDA will approve, 45 to 50 new medications a year. Despite the fact that pain was the fastest growing condition in America, there had been no new medications approved for pain since 1998. Celecoxib was the last one that was approved for pain. And why is that? I mean, bad problem, significant problem, 20% of the population, fast growing problem. Sometimes there are certain things, in this case opioids, which basically suck up all the oxygen in the room and make it very hard for true scientific progress to happen. That's changed. And part of it is that there are new modalities, obviously focused ultrasound, but also a new medication got approved in March of last year for the first time, suzetrigine, but also a lot of existing modalities which just never got the attention they deserved. We talked about things like mindfulness. For a lot of people, they still think of that as fringe, mostly because, opioids were commanding all the oxygen in the room.
Right.
Other things like nerve blocks and ketamine and again, obviously using sound energy. There's a lot of hope out there for people with chronic pain. And in the United States, that's 50 million people we're talking about in this country alone.
Wow. So yes, talking about the opioid epidemic, how we've actually done studies, as you know, that focused ultrasound can treat that, but let's stop the problem from happening, right?
That's right.
Let's use these other modalities. So thank you for those last words, and I encourage all the patients to educate themselves and find out about all of these options and discuss them with your caregivers and your physicians.
This episode of Curing with Sound has been presented by the Focused Ultrasound Foundation. If you'd like to learn more about Focused Ultrasound or the Foundation, visit our website at fussfoundation.org, where you can also find the full version of this webinar. While there, you can also sign up for our newsletter and news digest and follow us on social media. Be sure to subscribe to the Curing with Sound podcast so you don't miss the latest news on Focused Ultrasound. We would also be grateful if you would rate and review the show.